Most people who undergo stroke recovery usually develop to a point whereby there's stagnation in the progress of recovery. This is what they usually call the plateau phase. So at this point, there is no progress in terms of recovery. So what happens at this point is that you have developed what we call the learned non-use. So this is a phenomenon in which you learn not to use the weaker upper limb. So you learn not to use the weaker upper limb. So what happens is that as you develop the neurological injury, that is stroke, your body will sense a negative feedback, and this will lead to a compensatory behavior. So usually you will start by doing unsuccessful motor attempts. For example, you will try to brush your teeth, you will try doing grooming, but you will fail. So what happens is that as you fail to do this, repeated failure will affect your behavior, and therefore you will start now compensating using your normal side. You start compensating using the normal side, and therefore you abandon the weaker arm. And therefore, this is what we call the learned non-use phenomenon. So with the onset of stroke or hemiplegia, you attempt movement using the weaker arm. However, failure will result into a negative feedback and frustration. So as this happens, you develop compensatory behavior. You develop compensatory mechanisms whereby you use your stronger side, and as you use your stronger side, you learn not to use the weaker arm, and this results into what we call the masking of recovery, which means the recovery process of the weaker arm slows down. So to solve this, there is a technique that is called constraint-induced movement therapy. So in constraint-induced movement therapy, this is whereby the weaker arm is put into use. Your weaker arm is put into use. For example, if your right upper limb was the weaker arm, it is now put into use. And how does this happen? Your stronger arm will be restricted. This can be by use of a splint or anything. So we restrict the stronger arm, and as we restrict the stronger arm, which means that we have sent the stronger arm on a holiday, and then the weaker arm is enrolled into an active and intense training program. And as it is involved in an intense training program, signals, the sensory and motor signals, will be able to be sent and transmitted through the sensory modulation center, that is through your brain. And what happens is that this will lead to a neuroplasticity, which is the ability of your brain to adapt, repair, and reorganize itself following the neurological insult. So the weaker arm is put into use, and as it is put into use, it will be able to develop, it will be able to adjust, to adapt, and to reorganize itself, and the motor homunculus, that is the area within your brain that is responsible for the upper arm movement, will now increase in size. That is the increase in the size of the paretic upper limb within the motor homunculus, and therefore there will be increase in firing. With CIMT, that is constraint-induced movement therapy, this usually takes a long time, and it usually requires around 4 hours of intense training program per day. Around 4 hours of intense training program per day, and it should be done at least 3 times in a week. So it has 3 pillars, that is the pillars of the constraint-induced movement therapy. Number 1, we have intensity, which means that we should do a very high intensity. However, this doesn't mean that pain. we focus on high intensity but to the limit of pain. Then repetition. Your brain relies on repetitive movement. That is also another principle of neuroplasticity. Remember, we are now in the process of learning an old behavior which is now like a new behavior. For example, if it is grooming, we have to do it several times in order for you to be able to learn it. Then task-specific practice. So as we do the tasks, we focus on task-specific training. We don't just do the CIMT program without being specific to the task. For example, if it is brushing of the teeth, the aim should be to increase the fine motor muscles such that you are now able to brush the teeth. Same to grasping or holding a cup. And as I have said, repetition is key at this point. Usually requires around 4 hours per day of training, intense training program. Then we can also have a supervised training program. This is whereby you do it within the clinic, and then also an unsupervised one whereby you now do it at home. So after doing it at the clinic for around 3 to 4 hours per day, you proceed at home and do the same activity. So this will lead to the concept of neuroplasticity, which is the ability of your brain to adapt, repair, and reorganize itself following the neurological insult. So with the masking of recovery that occurred from the London use, there will be resolution of the brain edema and then activation of penumbra. This leads to neuroplasticity. So after doing CIMT, if an MRI of the brain is taken, there will be an increase in the size of the paretic upper limb. If they check the size of the paretic upper limb, there will be an increase in the size of the paretic upper limb. And how does this occur? Number one, we constrain the stronger arm. That means that we send it the stronger arm on a holiday, and as it is sent to a holiday, the weaker side arm is put in an intensive training program. It is put in an intensive training program. And therefore, different sets of functional exercises can be designed based on the potential of the patient. And I have said that we have two types of programs. We have the supervised and the self activities of daily living training. So this is a very, very effective rehabilitation technique that is evidence-based. If combined with the task training, task-specific practice, it leads to a wonderful result. So knowledge is power.